Sepsis is a life-threatening condition that occurs when the body has a dysregulated response to an infection, leading to organ dysfunction. In simple terms, the immune system is trying to fight an infection, but the response becomes harmful and starts damaging the patient's own tissues and organs. This can affect many organs. The patient may become confused because the brain is affected, need more oxygen because the lungs are affected, pass less urine because the kidneys are affected, develop low blood pressure because the circulation is affected, or have abnormal blood tests such as elevated bilirubin, rising creatinine, or low platelets. The infection can begin anywhere in the body. Common sources include the lungs, urinary tract, abdomen, skin and soft tissues, or bloodstream. Previously, sepsis was often identified using the SIRS criteria together with suspected or confirmed infection. SIRS stands for Systemic Inflammatory Response Syndrome. The criteria included abnormal temperature, tachycardia, tachypnea, and an abnormal white blood cell count. A patient was traditionally thought to have sepsis when they had an infection and met 2 or more SIRS criteria. However, this approach had important limitations. SIRS is not specific for sepsis. A patient can meet SIRS criteria because of trauma, surgery, pancreatitis, burns, or other non-infectious causes of inflammation. At the same time, some patients with severe infection and organ dysfunction may not meet 2 SIRS criteria, especially older patients or patients with impaired immune responses. Because of this, the sepsis tree definition shifted the focus away from inflammation alone and toward organ dysfunction. In adults, sepsis is identified as suspected or confirmed infection together with acute organ dysfunction. Operationally, this is usually represented by an increase in the SOFA score of 2 points or more from baseline. SOFA stands for Sequential Organ Failure Assessment. It assesses 6 organ systems: the lungs, coagulation, liver, cardiovascular system, central nervous system, and kidneys. The important clinical message is this: infection becomes sepsis when it is causing acute organ dysfunction. Therefore, when I suspect infection, I actively look for signs of organ dysfunction. I assess the patient's mental state, respiratory status, oxygen requirement, blood pressure, urine output, renal function, platelets, bilirubin, lactate, and overall clinical deterioration. Sepsis is a medical emergency. We should not wait for a score alone before escalating care, taking cultures when appropriate, starting treatment, and searching for the source of infection. Septic shock is the most severe form of sepsis. It is a subset of sepsis in which the infection causes profound circulatory and metabolic abnormalities. These abnormalities are associated with a much higher risk of death than sepsis alone. In simple terms, the patient has sepsis, but the circulation is failing despite initial fluid resuscitation. The blood pressure remains too low, tissues may not receive enough oxygenated blood, and the cells show evidence of metabolic stress. Under the sepsis 3 definition, septic shock is identified when a patient with sepsis still needs vasopressor medication to maintain a mean arterial pressure, or MAP, of at least 65 mm of mercury, despite adequate fluid resuscitation. Vasopressors are medicines that constrict blood vessels and support blood pressure. The first-line vasopressor in septic shock is usually norepinephrine. The patient must also have a serum lactate level above 2 millimoles per liter after adequate fluid resuscitation and in the absence of another explanation such as persistent hypovolemia. Lactate is a marker of cellular and metabolic stress. An elevated lactate does not always mean that the patient is simply not getting enough oxygen, but in septic shock it can indicate impaired tissue perfusion, altered cellular metabolism, or both. Therefore, septic shock means sepsis plus persistent hypertension requiring vasopressors to maintain a MAP of 65 or above, together with a lactate above 2 millimoles per liter despite adequate fluid resuscitation. Septic shock is a medical emergency. Management includes immediate assessment of airway, breathing, circulation, and mental state, obtaining cultures when this does not delay treatment, giving appropriate antimicrobial therapy promptly, fluid resuscitation guided by the patient's condition, starting vasopressors when needed, monitoring lactate and urine output, and identifying and controlling the source of infection. Systemic Inflammatory Response Syndrome, or SIRS, describes a widespread inflammatory response in the body. It can be triggered by an infection, but it can also happen without infection. For example, trauma, major surgery, burns, pancreatitis, or other severe inflammatory conditions can cause SIRS. In simple terms, the body is reacting strongly to a major insult. This reaction may cause fever or low temperature, a fast heart rate, faster breathing, and changes in the white blood cell count. SIRS is present when the patient meets two or more of four criteria. The first criterion is temperature, above 38 degrees Celsius or below 36 degrees Celsius. The second criterion is heart rate, above 90 beats per minute. The third criterion is respiratory rate above 20 breaths per minute, or a low arterial carbon dioxide level. The fourth criterion is the white blood cell count. This is abnormal if it is above 12,000 per cubic millimeter, below 4,000 per cubic millimeter, or if more than 10% of the white cells are immature neutrophils called band cells. Band cells are immature neutrophils released from the bone marrow when the body needs to respond rapidly to infection or inflammation. Historically, a patient with suspected or confirmed infection plus 2 or more SIR as criteria was described as having sepsis. However, SIRS is not specific for infection or sepsis. A patient may meet SIRS criteria because of trauma, surgery, burns, pancreatitis, or other non-infectious conditions. On the other hand, some patients with serious infection and organ dysfunction may not meet 2 SIRS criteria. For this reason, modern sepsis definitions focus on infection causing acute organ dysfunction rather than infection plus SIRS alone. Therefore, SIRS can still be useful as an early warning sign of systemic inflammation, but it should never be used alone to diagnose or exclude sepsis. Previously, clinicians used the term severe sepsis. Severe sepsis meant sepsis together with dysfunction of at least one organ system. For example, a patient with infection and low blood pressure, confusion, acute kidney injury, low urine output, hypoxemia, raised bilirubin, thrombocytopenia, or an elevated lactate could have been described as having severe sepsis. However, this term is now outdated. Under the modern sepsis 3 definition, sepsis already means life-threatening organ dysfunction caused by a dysregulated response to infection. Therefore, the word severe is no longer needed. In current practice, it is better to say that the patient has sepsis with acute organ dysfunction and then describe which organ systems are affected. For example, I might say, this patient has sepsis with acute kidney injury, hypertension, and altered mental status. If the patient has persistent hypertension requiring vasopressors and an elevated lactate despite adequate fluid resuscitation, this is called septic shock. Multiple organ dysfunction syndrome, or MODS, means progressive dysfunction of 2 or more organ systems. It may occur in severe infection and sepsis, but it can also occur after trauma, burns, pancreatitis, major surgery, or prolonged shock. The affected organs may include the lungs, kidneys, liver, cardiovascular system, brain, and coagulation system. For example, a patient may develop acute respiratory failure requiring oxygen or ventilation, acute kidney injury with reduced urine output, hypertension requiring vasopressors, confusion or reduced consciousness, thrombocytopenia, and rise in bilirubin. MODS can be potentially reversible if the cause is recognized and treated early. However, the risk of death rises as more organs become involved and as the severity of dysfunction increases. In practice, rather than simply saying MODS, it is helpful to state exactly which organs are failing and how severe the dysfunction is. Bacteremia means the presence of bacteria in the bloodstream. It may occur during a serious bacterial infection, but it can also be brief and harmless. For example, transient bacteremia can occur after dental work, brushing teeth, invasive procedures, or manipulation of infected tissue. Many episodes of transient bacteremia are cleared by the immune system without causing symptoms. However, bacteremia can sometimes lead to serious complications. Bacteria may seed other parts of the body and cause infections such as endocarditis, vertebral osteomyelitis, septic arthritis, or abscesses. It can also trigger sepsis if the patient develops a dysregulated response with organ dysfunction. It is important to remember that bacteremia and sepsis are not the same thing. Bacteremia means bacteria present in the blood. Sepsis means infection is causing life-threatening organ dysfunction. A patient may have bacteremia without sepsis, and a patient may have sepsis even when blood cultures are negative. Next, I assess QuickSOFA, which stands for Quick Sequential Organ Failure Assessment. QuickSOFA is a simple bedside warning score used in adults with suspected infection especially outside the intensive care unit, such as in the emergency department, on the ward, or in the pre-hospital setting. It does not diagnose sepsis by itself. Instead, it helps identify patients with suspected infection who may be deteriorating and who need urgent assessment for organ dysfunction. Quick SOFA has 3 criteria, and each criterion gives 1 point. The first criterion is a respiratory rate of 22 breaths per minute or more. This may show that the patient is developing respiratory distress, metabolic acidosis, hypoxemia, or systemic deterioration. The second criterion is a systolic blood pressure of 100 millimeters of mercury or lower. This may indicate that the circulation is beginning to fail and that the patient may have poor tissue perfusion. The third criterion is altered mental state. This means the patient is newly confused, drowsy, less alert, or has a reduced Glasgow Coma Scale score. New confusion in a patient with suspected infection should always be taken seriously. The score ranges from 0 to 3. A patient with 2 or more positive quick SOFA criteria has a higher risk of poor outcome and should be assessed urgently for sepsis-related organ dysfunction. At that point, I do not stop at the quick SOFA score. I assess the patient's airway, breathing, circulation, mental state, urine output, oxygen requirement, lactate, renal function, bilirubin, platelets, blood gas, and overall clinical condition. I also look for the source of infection and escalate care early if the patient is deteriorating. It is also important to remember that a low quick SOFA score does not rule out sepsis. A patient can still have serious infection and organ dysfunction even with a quick SOFA score of 0 or 1. Clinical judgment remains essential. Management of septic shock begins immediately. Septic shock is a medical emergency, so diagnostics and treatment must happen at the same time. We do not wait for every blood result or every imaging study before beginning resuscitation. The first step is to recognize the patient at risk. Screening tools and local sepsis pathways can help identify deteriorating patients, but no screening score can replace clinical judgment. A patient with suspected infection, hypertension, altered mental state, respiratory distress, poor urine output, mottled skin, or rising lactate requires urgent assessment, even if a screening score is not clearly positive. I begin with an ABCDE assessment. First, assess the airway and make sure it is patterned. Then assess breathing by checking respiratory rate, oxygen saturation, work of breathing, and the need for oxygen or ventilatory support. Next, assess circulation. Measure blood pressure, heart rate, capillary refill, peripheral perfusion, skin temperature, urine output, and signs of shock. Then assess disability, including the patient's level of consciousness, new confusion, and Glasgow Coma Scale. Finally, expose the patient appropriately and look for a possible source of infection, such as pneumonia, urinary infection, abdominal infection, skin or soft tissue infection, an infected line, wound infection, or an abscess. Secure intravenous access as early as possible, ideally with 2 large-bore peripheral cannulas. Start continuous monitoring with pulse oximetry, frequent blood pressure measurements, cardiac monitoring, and repeated assessment of mental state and urine output. Initial investigations include blood gas analysis, serum lactate, full blood count, renal function, liver tests, electrolytes, coagulation studies, glucose, and other tests guided by the clinical picture. Lactate is useful because an elevated or rising lactate may indicate significant metabolic stress and impaired perfusion. However, lactate should never be interpreted alone. Assess it together with the patient's blood pressure, peripheral perfusion, urine output, mental state, and overall clinical condition. Obtain appropriate microbiological samples as soon as possible, including blood cultures when indicated. Blood cultures should ideally be collected before antimicrobial treatment, but treatment should not be delayed if obtaining cultures will take too long. For fluid resuscitation, give intravenous crystalloid. Remember to reassess signs of fluid overload, especially in patients with heart failure, renal impairment, pulmonary edema, or severe respiratory failure. Use blood pressure, capillary refill, urine output, lactate trend, lung examination, and dynamic measures of fluid responsiveness when available. If hypertension persists, start vasopressor treatment. In a severely unstable patient, vasopressors may be started at the same time as fluids, rather than waiting for fluid resuscitation to be completed. Norepinephrine is the usual first-line vasopressor. The initial target is a mean arterial pressure of approximately 65 mm of mercury. In septic shock, empiric antimicrobial therapy should be given immediately, ideally within 1 hour of recognition. The initial antibiotic choice should cover the likely source of infection and consider local resistance patterns, recent antibiotics, healthcare exposure, allergies, immune status, and risk factors for resistant organisms. Once microbiology results are available, treatment should be reviewed and narrowed when possible. At the same time, look actively for a source requiring source control. Source control means physically treating the origin of infection. Examples include draining an abscess, relieving an obstructed infected urinary tract, removing an infected vascular catheter, debriding necrotic tissue, treating a perforated viscus, or performing surgery when needed. When source control is required, it should be arranged as early as possible. Finally, management does not stop after the first hour. Septic shock requires continuous reassessment. Monitor blood pressure, heart rate, respiratory status, oxygen requirement, mental state, urine output, fluid balance, lactate trend, renal function, and the need for vasopressor support. Reassess the diagnosis, review cultures and imaging, identify alternative causes if the patient is not improving, and escalate to critical care early when needed. When we start antibiotics in septic shock, the first treatment is called empiric antibiotic therapy. Empiric means that we begin treatment before we know the exact organism. We choose antibiotics that are likely to cover the most dangerous and most likely bacteria for that patient, based on the suspected source of infection. The choice is not the same for every patient. We consider the likely focus of infection, whether the infection is community-acquired or hospital-acquired, previous culture results, recent antibiotic use, allergies, immune status, renal function, and the risk of resistant organisms. In septic shock, the initial regimen usually needs broad coverage for gram-negative bacteria and gram-positive bacteria. We also add anaerobic coverage when the source could involve anaerobic organisms, for example in abdominal infection, deep pelvic infection, necrotizing soft tissue infection, or some head and neck infections. A common broad-spectrum group is the beta-lactam antibiotics. Examples include piperacillin tazobactam, third-generation cephalosporins such as cefotaxime, and carbapenems such as meropenem. In Norwegian hospital guidance, piperacillin tazobactam is a standard empiric option for septic shock when the source is unknown. Meropenem may be used when there is a significant risk of resistant gram-negative organisms such as ESBL-producing bacteria, or when local guidance recommends it. If the urinary tract is the likely source and there is no major risk of ESBL-producing bacteria, a cephalosporin such as cefotaxime may be appropriate according to local guideline. This avoids unnecessary anaerobic coverage. If an intra-abdominal source is suspected, the antibiotics must cover enteric gram-negative bacteria and anaerobes. This can be achieved with a regimen such as piperacillin tazobactam, or with combinations that include metronidazole for anaerobic coverage, depending on the local protocol and the suspected source. If there is a risk of MRSA, such as known colonization, previous MRSA infection, certain healthcare exposures, invasive devices, or severe skin and soft tissue infection, additional MRSA coverage may be needed. Examples include vancomycin or linezolid. However, MRSA coverage should not be given routinely to every patient with sepsis. Empiric antifungal treatment is also not routine. It is considered only in selected high-risk patients, for example patients who are severely immunosuppressed, have had prolonged broad-spectrum antibiotic exposure, have had a long hospital stay, or have a high-risk intra-abdominal source. Once blood cultures, other microbiological samples, and imaging results become available, we reassess the treatment. We narrow the antibiotic spectrum whenever possible. This is called de-escalation. De-escalation is important because it reduces unnecessary antibiotic exposure, toxicity, and selection of resistant organisms, while still ensuring that the patient receives effective treatment. The Hour 1 bundle is a group of urgent actions that should be started immediately when a patient has septic shock or a high likelihood of sepsis. The important principle is that assessment and treatment happen at the same time. We do not wait for every blood test, culture result, or imaging study before beginning life-saving treatment. The first action is to measure serum lactate. Lactate is a marker of metabolic stress and possible impaired tissue perfusion. A high lactate can indicate that the patient is seriously unwell, but it must always be interpreted together with the blood pressure, urine output, peripheral perfusion, mental state, blood gas, and the full clinical picture. The second action is to obtain blood cultures. We take blood cultures to identify the infecting organism and later guide antibiotic treatment. Ideally, cultures are taken before antibiotics are given. However, cultures must never significantly delay antibiotic administration in a patient with suspected septic shock. The third action is to administer empiric broad-spectrum antibiotics. In septic shock, antibiotics should be started immediately, ideally within 1 hour of recognition. The initial antibiotics should cover the most likely source of infection and take into account local resistance patterns, recent antibiotic exposure, allergies, immune status, and risk factors for resistant organisms. The fourth action is fluid resuscitation. If the patient has hypertension or a lactate of 4 millimoles per liter or higher, we begin rapid intravenous crystalloid administration. The traditional hour 1 bundle recommends 30 milliliters per kilogram of crystalloid. However, fluids must be reassessed continuously. We monitor blood pressure, capillary refill, urine output, lung examination, oxygen requirement, fluid balance, lactate trend, and signs of pulmonary edema or fluid overload. This is especially important in patients with heart failure, chronic kidney disease, or severe respiratory disease. The fifth action is vasopressor support. If hypertension persists during or after initial fluid resuscitation, we start vasopressors to support the circulation. In a profoundly unstable patient, vasopressors may be started at the same time as fluids, rather than waiting until all fluids have been given. The initial target is usually a mean arterial pressure, or MAP, of around 65 millimeters of mercury. Norepinephrine is the usual first-line vasopressor in septic shock. Therefore, the hour 1 bundle can be remembered as: measure lactate, take blood cultures, give broad-spectrum antibiotics, give void crystalloid when indicated, and start vasopressors if blood pressure remains low. But treatment does not stop after the first hour. We continue reassessing the patient, repeat lactate when appropriate, monitor organ function, identify the source of infection, arrange source control, narrow antibiotics when microbiology results are available, and escalate to critical care when needed. Thank you for listening. These are the key references and guidelines used in this presentation.